Good morning. My name is Jocelyn. I'm host of the group and the owner of the Vagina Doc Physical Therapy and Wellness. And today I wanted to come on and talk about the one thing I would change about how the medical system talks about prolapse. So before I get into that, I just hope you guys had a great weekend, great long weekend, Memorial Day weekend. And your morning is off to a good start. I woke up a little bit later than I wanted. I typically wake up at like 4:30 in the morning and then I'm working out at 5, but I let myself sleep because I didn't go to bed till like 10:30 last night. And I know that sleep is more important than me working out at this stage of my life. So I need to get moving in some capacity beyond just walking my dog. But so the one thing that I would change, well, let me just start with a story here. And then I'll tell you how that relates to this, why I'm coming live today. In December, I started getting help for prolapse symptoms. So I described them as it was vaginal heaviness, a lot of pressure in my perineal region. So the perineum is the region between the vaginal opening or the vagina and the anus. The slang term would be the taint. And just a lot of heaviness there. And so I got help, and it was really effective. So the approach that my therapist took was more of a myofascial release approach. My abdominal wall was super tight and fascially restricted. I could barely breathe into my stomach, and there was just nowhere for things to go. So my problem was how I communicate to you right now is like I have prolapse symptoms, but the diagnosis of prolapse is not helpful because my prolapse, if I'm communicating about prolapse, is different than a mom that just had her third baby's prolapse. Like that's different. Even on objectively, like if you're looking at the exam, if it looks similar when we're testing, that doesn't mean the approach is the same. So one thing I would change is how we talk about prolapse. I don't think prolapse is a helpful term, like at all, for at least PTs. So the one thing that I took away, or one really huge, the way I was trained at Washington University in St. Louis is our diagnostic language as physical therapists is such that it describes the cause of the problem. So prolapse is where your vaginal tissue, pelvic organ prolapse, the vaginal tissue descends to a given point, and the point that we're comparing it to is the opening of, or the hymenal plane, so where the opening of the vagina begins. And it just that is the problem, but why is it that way? So my diagnostic language is, okay, is it a force production problem or weakness of muscle performance weakness in that the vaginal walls cannot be supported, or the tissues, the pelvic floor and the passive tissues are not keeping the organs where they need to be. That's one. So force production deficit. And the second is motor control deficit or movement pattern coordination deficit. What that means is the timing of the muscle contractions during the day or at rest are inappropriate. So there could be an overactivity of the pelvic floor at the wrong time, or just at the time where it's not helpful, or it could be that there's not enough coordination between the pelvic floor and the other areas of the deep core and then other areas of the body. But it's a timing issue, a coordination issue. So when I'm saying coordination, just think about like juggling 3 balls. The other part that could be a driver of pelvic organ prolapse is impaired intra-abdominal pressure management. So that could be related, like what you guys know as diastasis recti. It could be that combined with it could be not that at all. It could be overactivity of the abdominal wall. That was pretty much me. I had really poor pressure management, not enough expansion of the abdominal wall, therefore too much internal body pressures. It could be, so internal body pressures, that could just be you're holding your breath for your everyday functional tasks, so you're not managing your pressures well there. And then a tissue impairment. So that is actual, like, more early on after a vaginal delivery. The tissue is just, you had an episiotomy or a forceps or vac-assisted delivery, and that tissue needs healed. Then there's what we call qualifiers to these diagnoses, and that would be, so I see you and you have a force production deficit or a movement pattern coordination impairment, and you have passive support loss. What does that mean? So passive support are the actual pelvic organ tissues. And because you don't see that in your body because it's deep in your pelvic cavity, think of if you've ever known anyone that had ACL reconstructive surgery. The anterior cruciate ligament is a passive tissue, and muscle contractions, a ligament is not attached to a muscle and a bone like a tendon is. It's typically a bony structure to a bony structure. Now, within the pelvic floor, it's a little bit different. It's more of like a connective fascial tissue, but still the same. It's passive. No muscle contractions are part of it. So if that's not there, so if the ACL is blown out, your stability depends on other factors. So that would be your muscle contractions, your hamstrings and your quads and your calves and other muscle tissues in that area. So for the pelvic floor, that would be, for prolapse, it would be the pelvic floor muscles. So in the case of passive support loss, and it's significant enough and it's symptomatic, then I know from a diagnostics language standpoint immediately, if I'm communicating that with a colleague, I'm like, hey, this person has force production deficit with passive support loss. I know exactly what intervention, if I'm on the receiving end of the provider, I know exactly what I'm going to do. I need to support the support loss. So that could be, depending on their stage of rehab, and I didn't get into that, stage 1, stage 2, stage 3. If it's early stages, I might want to support that with a pessary or something else immediately while we strengthen the tissues. Force production deficit tells me there needs to be some sort of strengthening of tissues. If I say, hey, movement pattern coordination deficit with passive support loss, we're going to be working on timing, and we need to support the tissues because the integrity of the pelvic organ passive support system is compromised. And then, of course, if it's tissue impairment, or there's another one, there's a nerve impairment, I have a whole different approach. It's like, okay, tissue, we need to focus on the tissue first. And then we, at our next every time we reassess. If I have to change the diagnosis, I do. Oftentimes, tissue impairment turns into force production deficit or movement pattern coordination deficit, and I know exactly what to do. Versus if it's just prolapse, well, so what? What does that even mean? Especially as a PT. So as a medical doctor, they're like, okay, prolapse, surgery, or some sort of aggressive intervention when it doesn't have to be aggressive. So that being said, whenever you're thinking about, when you read or hear that you have prolapse, I want you to think about hearing someone say, "Oh, I just bought a car." Well, what kind of car did you buy? Prolapse is like, "Hey, I just bought a car. I have a car." It doesn't tell me anything out. Like, just you have something. Versus if you say, "I got the Kia Forte 2011 and it's used." That tells me something. Okay, you have a sedan, it's used. It's a Kia. I know that it's not the highest end car. You get the idea. It's more specifics. I need specifics. Knowing that someone has a cystocele or a rectocele is really important for education. Really important for me to describe, okay, so what's this mean to what's happening on the toilet? This is what you might experience, and this is what you would do to problem solve through that. This is what I need you to do in terms of your diet, or this is what I need you to do in terms of the way that you are approaching your fluid intake. Or this is what you need to do to help you get all the poop out in case it's getting stuck in a pocket. So the cystocele, rectocele, that helps me understand education. It also helps me understand a little bit more, especially if you've had a POP-Q assessment. You would get that from a urogynecologist, more than likely, a good one. That tells me ways to understand either what your habits are in terms of what you're doing with your pelvis, because that tells me which wall of your vagina is sagging, essentially, or is drooping down. And so I know that if you're in a big anterior tilt of your pelvis like this, I know that is going to put more tension on part of the passive tissues. So I use that. I'm like, hey, you have this cystocele, and this is how you're standing. This is my suggestion, and this is what's happening to your pelvic ligaments when you're in that position. And then I tell you, these are what I need you to do to change to improve your situation. And I relate my suggestions of behavior change to the problem so you buy in. You following me? If this makes sense, I want you to comment, makes sense. This is really important because a lot of people fight the behavioral change. They're so out of touch with their body. It's like, oh, my body's betraying me, so I just don't even want to pay attention to it. What I mean by that, okay, my financial situation sucks right now, and I'm not doing a really good job documenting, budgeting, and writing everything down, following my numbers, because it's like painful to even think about it. But the thing is, that's not helping my situation. You, whether it's intentionally or unintentionally, not paying attention to your habits and being, I guess, ignorant, taking the ignorance as bliss, isn't always the most helpful approach. Now, I want to mention, though, being too much into your body and too much obsessed with the prolapse is just as bad. So you don't want that. It's adopting a healthy mindset around it. Okay, in summary, I talked to you about why the number one thing about the number one thing I would change about how we speak about prolapse in the medical community. And that's the diagnostic language, because the word prolapse is not helpful. And the one suggestion I would make is I want you to understand that there's even a deeper language where, like the one that I use is I identify the underlying cause. So force production deficit, movement pattern coordination deficit. And I use that along with the diagnosis, the medical diagnosis, to educate you on behavioral changes or things that you can do to help your situation a little bit more. This kind of language is less aggressive. Like, you don't think, oh, I need surgery. Oh, no, you understand that you have the power to improve your situation. Because all it is, changing movements, improving your movements, or improving tissue quality. And it doesn't, put your brain on this defense mechanism, which ultimately doesn't help your situation. So that is what I want you to start thinking about if you have prolapse. Like, what does that even mean? You have a car. Okay, what kind of car? Be more specific. Find someone that has this breadth of knowledge that can communicate this to you, because you need the buy-in in order to chip away at some of the things, habits, behaviors that you're doing that are not helping. That's all I have. So I just want to announce something really exciting to you guys. I'm completely changing my business model because I find that there are so many things that people can get out of just with education and changing a few things on their own and then inserting me into their lives when they need it versus seeing me in person right from the get-go, even a live virtual consult. So the way I'm changing my business is I have a system where you submit a subset of movements. You video yourself doing a subset of movements. You submit a form of what your problems are. You send that to me, and then I review all your videos and what your problem is, and I record my assessment to you, and I send it right back to you within 24 hours. And at that point, I say, okay, this person needs a little bit, can you do this, this, and this? And if you're good, you're good. And then I say, based on, you do this, this, and this, and then this might help you. You might benefit from, this plan that you're submitting these 4 virtual consults for a month, and that's a membership. And that way we're not bogged down by scheduling, by, time. It's short. You have immediate actionable steps, and you basically get to choose what level that you're working with me. And it's at the right time. And I might say, yeah, you would be a great candidate for me to see in person. Or no, you would be a great candidate to do virtual. Or you'd be a great candidate to enter my postpartum Restore, Revitalize, Reach program. Or you might just need to do Know Thy Pelvic Floor. You might need to see this person. So it's a great way to dip your feet in for help, because a lot of us pelvic health patients or people that have pelvic health dysfunction, we don't need constant direction from a healthcare professional. We have that within ourselves. We need to tap into that when we're ready. We're not always ready to be submerged in Jocelyn or another pelvic PT all at once. It took me a long time. I dipped my foot in and made changes for a couple years, and then I invested 8 to 12 visits one-on-one with a PT. So we have an amazing capacity to heal, but we need to be put in the right environment to do so. So that's why I've changed my business model, because I feel like I could cut people's visits in half or more by starting here. Now, I'm not doing this for free because the value is so high. And my time is so valuable, and I've been giving so much away of it for free. And I put a lot out for free out like in this group and so on. So I really want it to bring in people that are serious and are ready to change and change, in a way that they're not, there's no codependency being fostered with the relationship. So super excited to share that with you guys. If you are interested in going through being one of the first people to go through it, I'd love to hear your feedback. I'm doing a special where you sign up for your virtual consult and you get Know Thy Pelvic Floor and Pelvic Health 101 courses for free. And my virtual consult, like the Move virtual consults, are $49 for a pretty solid assessment. So super excited about that. If you watch this video on the live or on the replay, comment replay so other people could see it. And what are your takeaways? Did it make sense that, my diagnostic language for prolapse is different? I call it something different, or is that totally confusing? I will see you guys soon. Hope you have a great week, and I'll see you next time. Real Talk with the Vagina Doc.